I'm glad to present Fame. She needs no introduction. She's our star fellow in Nuevo Progreso. So, take it away, Fame. Go ahead.
Okay, so this time is my turn to present backgrounds. My name is Pamela Ruano, and I'm gonna start. So this patient, her first visit was in October the 2nd of 2023. It was a female patient with 82 years old. Her chief complaint was a decreased visual acuity of 2 years, both eyes. It was progressive, only associated with tearing. So asking the patient a little bit more about past medical history was denied. Drug history also denied. Family history also denied. The only thing that the patient referred was a cholecystectomy 10 years ago, and system review was negative. So talking a little bit about the ocular examination, the visual, starting with the right eye, the visual acuity was light perception. We couldn't refract her on this side because of the bad reflex. The IOP was 10. And on slit lamp, the positive things, it was nasal pterygium, reactive pupil, and a very dense cataract. The gonioscopy was an open angle. And on the left eye, the visual acuity was 2200. The refraction was the one that it's read down there. The IOP was 10. And on slit lamp, the positive was the nasal pterygium and a cataract with nuclear sclerosis 3+, and a posterior capsular 3+ also, and open angle. So it seems like it's a very normal patient for our people. With the fundus on the right eye, we couldn't see, the only thing we could see was the red reflex due to media opacity. And on the left eye, the posterior pole looked attached. The nerve was with a cup disc radio of 0.3, and it was really hard to evaluate periphery due to the media opacity. So this is the original management we performed with the patient, first visit, then surgical management. On October 11th of the right eye, it was an M6. Next day, it was performed also an M6 on the left eye with the pterygium resection. And because of the follow-up, the immediate follow-up of the patient was really good, we decided to follow her up in 1 month. So 1 month after the cataract surgeries in both eyes, the visual acuity of the right eye was 20/50. With this refraction, the IOP was 14, and on slit lamp, we could still see the nasal pterygium, the IOL was intact, and a posterior capsular opacity of 2+. And on the left eye, we could see the visual acuity was exactly the same before we performed surgery on her. So it was 2200 with this refraction. The IOP was 14. We could see the IOL in the back. Otherwise, the exam was normal. But this time, the blood pressure of the patient was 173/80. So we refer her to internal medicine. So we started investigating a little bit more of the patient, and on the fundus, on the right eye, I'm sorry for the back picture of the right eye, but this is what we got from the first exam we performed on her. So on the right eye, the retinal looked attached. The disc with cup disc radio was 0.2. Macula and fovea were unremarkable. And we could see some hypopigmented lesions outside the temporal arcades. On the left eye, the retina also looked attached. The cup disc radio was 0.3. We could see some RPE changes in the macula and elevated area close to the inferior temporal arcade. And we could see an intraretinal hemorrhage. And also the same hypopigmented lesions outside the arcade. So I'm gonna do a little bit zoom here. I'm sorry. So we could see on this arrow that I'm pointing the intraretinal hemorrhage that we could find. And here, we could see also the hypopigmented lesions I mentioned. So in the OCT, this is the green line here. It's showing where's the cut of the OCT. So in the OCT, what calls our attention, it was very important intraretinal edema and fluid accumulation, especially between the inner limiting membrane that it's located right here and the ganglion cell layer. Also some exudates that we could see surrounding the area. And as you can see in the other cuts that we had, we can see a lot of edema and also some cysts here too.
Pamela, maybe we could pause a little bit to hear everyone's thoughts about it.
Yeah, sure.
So I don't know if anyone wants to comment a little bit to make it a little more dynamic.
Well, from a cornea specialist point of view, I mean, I see intraretinal as well as subretinal fluid, and it's all inferior. Does it seep all the way to the macula? Is it involving the fovea, or is it just subfovea? I mean, inferior to the fovea.
It's inferior to the fovea.
And it doesn't involve the macula or the fovea at all?
No, no, no.
Okay.
Yes, it does involve the liquid. It's, I mean, the fluid. It does involve the fovea.
So it does track up.
Yeah,
to the fovea.
you can see there. That in that line, in that perspective, you can see we have a cyst on the fovea.
Are the inferior images through the fovea? Gotcha. Yeah, I mean, so when you see subretinal, intraretinal fluid like that, I mean, you worry about things like a retinal arterial aneurysm or other forms of serious retinal attachment as well. There's hemorrhage there. There's peripheral drusen. You know, you can get different types of degenerative changes like similar macular degeneration, but you get peripheral drusen that can cause that as well. But and it's near it seems to come from the inferior arcade, it looks like. That's all I have from a cornea perspective.
Thank you.
Thank you. That was really helpful.
Okay, Andy, you owe me one.
Thanks. Well, that was good. I mean, I think from a retinal perspective, you know, I agree. I think the differential with hypertension as the baseline risk factor is retinal arterial macroaneurysm, retinal vein occlusion. I think the fundus photo is a little bit difficult to appreciate, but it does look suspicious that there may be a RAM-like concern. I think the difference that I would initially say is that with the retinal vein occlusion, you know, it appears that the hemorrhage is a little bit more arterial in the location rather than along the vein inferiorly. And then on top of that, then the very interesting finding is that we have, sorry, I have kids in the background, sort of fluid within this like cavity between the internal limiting membrane and the neurofiber layer, which is kind of atypical of retinal vein occlusion. You would expect that more to be just intercystic fluid. So having fluid at the subretinal component, intraretinal, as well as in that sub-ILM is kind of more suspicious of possibly a RAM, and I think an angiogram would be helpful.
Thank you.
Thank you.
Can I ask a question then?
Yeah, sure.
I think yeah. So when I'm driving, so when I looked at that photograph, it looked like the first one, like a macro or macroaneurysm. But and I assume you'll talk about this. Is I guess I would be, when I looked at the OCT, I was surprised to see all the edema, and I'm wondering, is that typical then of a macroaneurysm, or is it just depending on what stage of the evolution you find it, if that's what it is?
Yeah, I don't know if Pamela is going to go into that in more detail, but I think from a standpoint of risk, obviously RAMs associated with hemorrhage in all compartments, vitreous hemorrhage, sub-ILM, intraretinal, subretinal, and then commonly they can have cystoid edema as well, and those are the indications for treatment. So, I mean, again, angiogram would be helpful to kind of clearly establish the diagnosis. I think on the OCT, you can kind of see the RAM in some of these cuts.
Yep.
Kind of that top cut, you can see kind of this, like in the smaller cyst, there's this like kind of reflective little nodule that's there. And I think that's the RAM. And I think the problem is that proximity to the fovea may be difficult to laser safely, but that would probably be more amenable, although there's treatment now, like anti-VEGF has been shown to be somewhat effective for RAMs as well. So that would probably be kind of my first thought as well.
So yeah, as Dr. Jesse was saying, at this point we were having a lot of differential diagnoses, like with AMD or neovascular polypoid membrane or macroaneurysm or a DME or a Valsalva hemorrhage, trauma, uncontrolled hypertension, or macular dystrophy because of the drusen or drusen like the outside the arcades. So when we consult retinal department, Dr. Young and Dr. Mateo were checking for the OCT, and we could find a round oval hyperreflective lesion in the inner wall layers, and this caused like shadowing of the deeper tissues that we could see right here. So at this point, we knew it was macroaneurysm. So we start with the treatment. At this point, the patient was referred for anti-VEGF treatment, Avastin, 1 dose, and focal laser. We can see here the picture of the laser that was given. So this is a picture post-focal laser. After focal laser, we can see some hard exudates perilesional and in the area of the macula, and also RPE changes in the area where the laser was given. In the OCT, after treatment, we can see that the layers have no distortion or edema, and the only thing we can see is some exudates in the inner layers. Here's another picture of the OCT where we can see the thickness values are back to normal and no longer edema is present. So maybe this is the two pictures that we can compare. The first one, it was taken in November, the visual acuity, but this time was 2200. It was before the treatment, and here we can see the macroaneurysm. And after, this is the picture 6 months after, that it's recently from May, and the visual acuity is 20/80 uncorrected. Also, we took some photos of the lesions that were outside the arcades. Here we can see the linear cut of the area of the lesions. There is subretinal drusen-like formation, but they look like above the RPE right here. So we were thinking in a pattern dystrophy. And I'm going to talk a little bit about macroaneurysm, RAMs. They acquire focal dilation of a retinal artery, usually occurring between the first 3 orders of bifurcation of the central retinal arterioles, or at the level of the arteriovenous crossends. The usually most common arterial that is affected, it's supratemporal. They tend to be symptomatic. But usually when they're complicated with macular edema or an arterial occlusion due to thrombosis, or when there's rupture of the macroaneurysm, they can present with hemorrhage. So this can affect the vision. Some of the risk factors for this is hypertension, arteriosclerosis, abnormal lipids levels, and structural defects in blood vessels. These four can lead to focal ischemia of the wall blood vessels. This increases the permeability and also the intimal collagen remodeling. So this predisposes for the dilation of the saccular or fusiform vessels. Also, another risk factors are coat disease, von Hippel-Lindau disease, diabetic retinopathy, and radiation retinopathy. Talking a little bit about the epidemiology, it usually presents in elderly people from mid-60s to mid-70s. Females in 70% of the cases. The incidence is usually 1 per 9,000 eyes. Usually it's unilateral, and in 15 to 20% of the patients, it's multiple presentation. The type of ramps are quiescent, hemorrhagic, and exudative, and it depends on the presentation, if there's exudation or hemorrhage present in it, and if it's sparing of the macula. Usually when there's exudative, there's a lot of lipid deposition in a surstinate pattern, and there's intraretinal and subretinal fluid accumulation. Something characteristic of the hemorrhagic type is that they present with multi-layer hemorrhage, and the hemorrhage are more than 1 disc diameter. For the evaluation, we can use FFA, ICGA, OCT, OCTA, and USGB scan. FFA help us when we have a cure of the aneurysm because of hemorrhage or exudation. Usually we could see a round ovoid pooling of dye, filling rapid in the early stages. And we can see also leakage on this patient. For ECGA, we could see hyperfluorescence, suggesting the location of the macroaneurysm, and we can use it too for rule out a hyperpectic polypoidal choroidal vasculopathy. In the OCT, like the one we did with our patient, we could see the round or oval hyperreflective lesion, and also we can use it for determining the intraretinal of the retinal fluid and to follow up the patient. The same as OCTA. And the USGB, we can use it when the fundus is not visible, so we can rule out between rams or retinal tears. And there's some times that the management, it's just observation because of it's not complicated, or it's not macula involving, or it's not high risk for macula, because usually they're auto-limited. But the management, when they have any hemorrhage or subretinal fluid and this, we can use anti-VEGF. This anti-VEGF usually might alter the balance between coagulation and fibrinolysis and inside the RAM, and they can lead to thrombosis and RAM remodeling. The STLT, we can use it to improve the balance in cytokines release by causing selective damage to the retinal pigment cells. We can use it too for reducing the vascular permeability and improve the fluid reabsorption because this promotes vascular repair. And usually this is with minimal complications. We could also use direct laser photocoagulation or indirect laser photocoagulation. The direct laser, it helps sealing the aneurysm using minimal power, usually between 100 to 300 milliwatts. And the application, it's directly to the macroaneurysm to speed up involution and decrease the leakage. And when there's indirect, this reduces the consumption of oxygen and blood flow through the aneurysm, along with decreasing exudation from the surrounding capillaries. the direct thermal energy, we avoid dilation and we use confluent burns in a shorter duration. Some of the complications of these procedures can be arterial occlusion, retinal breaks, artery to vein shunting, choroidal neovascular membrane formation, extension of the exudation, and traction in the retina. So some points to take home is that we should include systemic evaluation for high blood pressure and ischemic heart disease for every patient with this pathology. It's also common of macroaneurysm to cause multi-layer hemorrhages and chronic edema. We can include differential diagnoses like diabetic retinopathy, retinal telangiectasia, fungible endowed disease, radiation retinopathy, polypoidal choroidal vasculopathy, and others. And it's the little details that are vital. And this is what I got for you tonight.
So, thank you, Pamela. That's a great case. I have a question. Does the OCT have OCTA angio or vascular thing?
Our
No.
OCT, no.
No. Oh, it doesn't. Oh.
I mean, we do have, but the problem is that the software, I mean, like, Jesse fixed the problem with the software, but it just always pops the announcement of license problem, but we are capable of. We just have to kind of talk to them all the time, so we just kind of give up a little bit with that.
And here's another question, Isa. So would you do this this laser? Did you do this laser, and did you do it just by looking at the picture, like focusing exactly, or would it be FA guided? Would that be easier for you?
Well, ideal, we should have an FA because that will be more easy to like target. Thanks God, we could see it, and Jesse brought us 3 mirror lens, so we were able to do this treatment. I remember we kind of used a patient with we kind of used Avastin previously, and of course didn't happen, and nothing happened. And I also gave laser twice because I didn't have any reaction at the first one. I probably was a little bit afraid because it was so close, and I kind of did it without an FA, and I was used to doing it with that in Robles. So yes, of course, I will. If I have the resource, I will use it.
Does the Avastin not work because these vessels are larger diameter vessels because they're in those first 2 or 3 subdivisions of the arcades, or what's the thought behind why Avastin's not as effective?
Avastin does have an effect, but not as good and fast as the laser.
It's interesting. And my related question is, why don't you see these aneurysms further out in the peripheral retina? And kind of related to that is, I think I've never seen an aneurysm on any of the iris vessels, although we do have periodic spontaneous iris hyphemas. So I'm wondering if that's, I don't know, just wondering why they're prevalent in the posterior pole and not elsewhere.
Hey Andy, I missed the question earlier, sorry. But at least to answer that, I mean, I don't know, Isa, if you have any extra thoughts, but from a standpoint of the posterior pole, a lot of it has to do with like the size, the arteriolar size, but you can see it peripheral. It's not necessarily just locally to the posterior pole, and the peripheral ones tend to be things that you observe. and don't have to treat. And then I think on the iris vessels, I'm not sure if those are venules versus arterials, but if you do have arterials, obviously it could depend on the caliber of the arterial that actually makes it more susceptible to an aneurysm versus not. So I guess the presumption is that the bifurcations are actually higher risk areas for these arterial or aneurysms to form. And anti-VEGF, this is not really a VEGF driven process, so that's why it doesn't have as much sort of effect. But it does, anti-VEGF injections do stabilize vessels. That's why they work to some degree, especially in other things like DME as well. But it's not all just VEGF based process, at least from the standpoint of aneurysms. So that's why it's not as effective.
So it's not neovascular, it's just a deformed arterial wall that dilates and then
leaks.
Okay.
Yeah.
All right. Good.
Yeah. So Isa, I don't know if you had any comments about the iris as well as the posterior versus peripheral, but or if Pamela has anything when she looked at the literature.
Yes, I was gonna say that I haven't read anything about aneurysm in the iris. Will be interesting to see what the literature said about that. But yeah.
I mean, I suppose you wouldn't even care about in retinal aneurysms that they didn't cause edema and visual loss. But it seems like we would notice just clinically iris aneurysms if they were present. So there must just be something different in the type of vessel structure. I'll look that up, find out.
I'm gonna look for that too, Dr. Sorenso, but I didn't read anything about iris aneurysm or aneurysm. Yeah.
Oh, I wanted to add too that I was teach to kind of treat even the periphery aneurysm because of our context. We usually in the United States, you kind of observe a lot of patients, but sometimes we see patient, treat patient because we might never see him again.
Right.
Yeah, that's a good point, obviously.
And the peripheral.
Yeah, go ahead, Andy. Sorry.
No, you go ahead. You go ahead.
I was just saying that's a good point, but I think, classically, the treatment for retinal macroaneurysms is vision-threatening edema in the macula or vitreous hemorrhage that is coming from the aneurysm. So that's why a lot of these will self-involute and consolidate on their own. So that's why we don't actively treat every single macroaneurysm that we see.
Bame, I have one last question. Me, from the glaucoma standpoint, what is STLT?
Subthreshold laser.
Oh, subthreshold, of course. Yeah, okay. Yeah, I get it. Thank you. All right. All right, if there are no more comments, you're really on time. Pame, you're the best. And yeah, I mean, this is a great case, and we got all the information and great. Do you want to say something, Andy?
Nope. Thank you. Perfect.
Yeah. We try to promise half an hour, so this is all for today. And thank you, Pame. Thank you, Isa, and thank you, Jesse, for the discussions. We learned a lot today.
Yeah, thank you.
Thanks, guys. Have a good night.
Yeah.
Thank you.
Thank you.